and we are dedicated to improving health equity in Washington, D.C. So if people have not looked at the Department of Health's health equity report about post-pandemic and what the city, sort of the health impact of COVID has been on the city, I would highly, highly urge you to look it up. Sadly, all the disparities, whether cancer or screening and mortality or, heart disease or stroke or whatever, have gotten actually much, much worse since the COVID for the groups that are already suffering from the greatest disparities. I would really encourage you to look at that. I think that there's some good information that should help us sort of not reinvigorate us, that's not the right word, but make sure that we redouble our efforts in terms of handling these big gaps. Want to remind everybody that we are not only in COVID season, but now we're entering flu season. I would encourage as many of you to get vaccinated with influenza. If you're above 65 or if you have any healthcare issues, you should definitely consider getting the high dose flu vaccine. And already there are outbreaks, not in DC yet, as far as I know, but I think in Louisiana. Now, remember that the flu kills about 50,000 people every year, which of course pales into comparison with COVID, right? We've lost, I think, 750,000 people in the United States over the last couple of years. But the reason that it would be helpful to get the flu vaccine is because it's really going to be tough to distinguish between the flu, the COVID, a regular cold, or even allergies. So as much as people can protect themselves, that would be really great. We're now in the phase of vaccinating children, and Pfizer just announced that they are approving the COVID treatment, which is a pill, which I hope is going to be a further game changer. But remember, since we're all going to be gathering with each other during the holiday season, if there's anybody who has not gotten vaccinated in the family, please be hyper vigilant about keeping your masks on and washing hands and physical distancing. I know that's tough in a family setting, but unless you're all fully vaccinated, that's what we would recommend and what the recommendations are. All right, well, without further ado, I'm very excited to introduce Dr. Keith Mortman. Dr. Mortman is the chair of cardiothoracic surgery at GW. And before he starts, I want to tell you that one of the things that I really admire about Dr. Mortman, aside from the fact that he's an excellent surgeon and excellent doctor with a great bedside manner, is that actually, I want to say maybe close to 15 years ago, and he'll correct me if I'm wrong, he started this program where he was teaching, he does teach high school students about the problems that arise from smoking. But he also brings in high school students to the hospital so that they can virtually watch him operate and get to meet the team of people that he works with. And then they come up after the operation and they talk to the students to tell them about their career trajectories, their, what it took for education in terms of how much education they need, what the pay is, what the things that they love about their job. So Dr. Mortman is not only a clinician and educator in terms of the medical setting, but also he is somebody that's forwarding the agenda of a workforce development by trying to get young people interested in the health career workforce from diverse backgrounds. So with that, I'd like to welcome you, Dr. Mortman. Welcome.
Thank you. Thank you very much, my dear friend, Dr. Albayumi and Mrs. Shanti, for putting this together. Thank you for inviting me this evening, particularly during the month of November, which I think many of our guests might know is actually Lung Cancer Awareness Month. So typically our program does host a number of events during the month, which obviously have been on hold for the past 2 years, unfortunately, with the COVID pandemic. But thank you for asking me to speak with everybody this evening. Thank you for the opportunity. Thank you for the plug for our program that we call STATS, or Students Attending Thoracic Surgery, right, which I started about 16 years ago, which has also been on hold for almost 2 years now, again, because of the COVID pandemic. So hopefully we'll be able to start that in the very near future. So tonight I was asked to speak to the group about how I see the intersection of technology and medicine and how I use that in my daily practice, and kind of tie in a little bit of lung cancer and how we address lung cancer in 2021, and touching a little bit on some of those health disparities that you mentioned, Gigi. So this is a little bit of about 3 or 4 different talks, all blended into one. We'll try and keep it at a sort of high level view. And I'm going to go ahead and share my screen and we'll get into it. Again, this is somewhat informal, so if there are questions along the way, you can put those into the chat and we will monitor those. Okay, and everybody can see this okay?
Yep.
Okay, excellent. So as I said, so this will be about the intersection of technology and medicine and how we address specifically lung cancer in 2021. Just have to disclose some of the relationships I have, none of which are really relevant to tonight's talk, some of the companies for which I consult and speak for. So let's talk about technology and medicine and how did we get from the basic stethoscope to high resolution PET CT scans, an example of advanced imaging that we use. And how do we get from that reflex hammer to a cardiopulmonary bypass or heart-lung machine, and a simple tuning fork into augmented reality and artificial intelligence. So if you think about it, we've really come a long way in a relatively short period of time. And if we take a look, an abbreviated look at some of the milestones in medical technology, that stethoscope that I just showed you was invented just over 200 years ago. The first use of X-ray was in the late 1800s, followed just a few years later by the first EKG machine. The ubiquitous Band-Aid was invented just about 100 years ago. And then we started making some bigger strides and inventing some bigger things, such as the iron lung. That cardiopulmonary bypass machine that I just showed you came along in the 50s, followed a couple of years later by the first use of ultrasound in pregnant women. And then you fast forward a couple of decades, and minimally invasive surgery really took hold around 1980, in the early 80s, initially with abdominal surgery, followed about a decade later, 1990, in the early 90s, we started using that in the chest. And then around the mid 2000s, we started doing robotic surgery. And here we are today with the use of virtual reality, which I'll show you in a few minutes, as well as augmented reality and more advanced artificial intelligence. So this is just kind of a snapshot of where we've come over the past 200 years or so. Now, as Dr. El-Bayoumi said, I'm the chief of thoracic surgery here. And if we think about how thoracic surgery really started and how it's been done for over 100 years now, it really started by making this relatively large incision, usually on the side or towards the back of the chest. As you can see, we place a retractor so that we can spread the ribs apart and literally get our hands into somebody's chest, whether it's to take out a lung cancer, whether it's to take out an esophageal tumor or a mediastinal mass in the middle part of the chest. Could actually get our hands in there, and I've got some pretty big hands, so I need a larger incision. But as you can imagine, there are some downsides to this approach. The visualization is great because we can see everything that we need to see, but it's not necessarily the best approach for the patient. And we certainly didn't realize that 100 years ago, but with more advanced imaging and techniques these days, as I mentioned, once we started doing minimally invasive surgery, we really started to be able to see the difference between the two. And being in academic medicine, I and others, we started studying that. So we started honestly looking at our outcomes between the minimally invasive approach and this open approach. So that these days I can do the same operation, but instead of doing it through this approach, I can do it like this. So a much more benign, if you will, approach, smaller incisions. Over here, I can put a scope into the chest. I might use a stapler and some other retracting instruments. And probably the greatest example of this has to do with a particular operation that I do called a sympathectomy, where we actually divide a very small nerve in the chest for a condition called hyperhidrosis, which is essentially excessive sweating of the hands, of the palms. Now, we've known for, again, over 100 years that that particular nerve controlled the excess sweating. But prior to the advent of minimally invasive surgery, you'd have to make a relatively large incision, like I said, retract the ribs, which causes a fair amount of pain, just to simply kind of cut that nerve and cure that condition. And with any surgery we do, we always weigh the risks versus the benefits. And before minimally invasive surgery, there's probably more risk than benefit with that surgery. But these days, it's probably the most minimally invasive operation that I do. I can do that operation today literally through 2 pinpoint incisions with the use of a 2 mm scope. So in the era of open surgery, you'd probably be in the hospital for 3 days just to kind of cut that nerve, and you'd have a drainage tube, which would come out after a couple of days. And now fast forward, I can do that operation in about 25 minutes, and the patient goes home an hour after surgery. So it's really a question of, well, what were our needs in surgery? Where's technology, and kind of marrying those two. So now I'll show you an example of a very routine operation that I do. So this is a minimally invasive lung operation. Here we're using a 5 mm scope. The patient is with the right side up. So this is their front over here, and this is their back. You're looking at the right lung. This is the diaphragm. Hopefully everybody can see my pointer. And this person has a nodule in the right middle lobe, which is this purple area. And the first thing I need to do is I need to confirm the presence of the pathology. So we literally kind of put my finger in through one of those small incisions, making sure that that nodule is in the same place as where I saw it on the preoperative CT scan. I'm using one of the surgical staplers that are available to us. And this device will simultaneously fire 6 rows of staples, and it's got a knife blade that cuts the tissue between the 2 middle rows. So you'll see there's 3 rows of staples on part of the lung staying in, 3 rows on the side coming out. So again, might be the most common operation I do these days. People have various types of lung nodules, and some of them are cancer. This particular patient, very common scenario, we take him to the operating room for a nodule that was suspicious for cancer, but we didn't know for sure. We extract the specimen through a bag in case it is cancer. We don't want to drag cancer cells through the chest wall. And I'm kind of looking at it there on the back table, and I say, aha, that's pretty suspicious looking. And we send that to the pathologist to examine under the microscope. And in that case, as in many others, they did confirm that that was a lung cancer. And we do the rest of a lung cancer operation, which is taking out the rest of that lobe and some lymph nodes during the same anesthetic. So again, this has been extensively studied over the last several decades. And we know that the benefits of minimally invasive surgery are real. Now, early on, there were a lot of naysayers, even within my field. Some of the, quote unquote, old timers who were used to doing big open surgery would say, well, gee, it's simply a smaller incision. It's just a cosmetic thing. And it didn't take very long to disprove that. So we know that there's less pain involved with minimally invasive surgery, pretty much on every subjective as well as objective measurement. We know there's decreased perioperative morbidity. There's a reduced stress response that we can actually measure, certain cytokines. Patients have a chest tube after chest surgery, and we know that that tube can come out sooner after a minimally invasive approach. That means we can get patients home faster, so shorter hospital stay. Quicker return to normal activities. So whether it's simply walking a dog or going back to swinging a golf club, we can get our patients back sooner with a minimally invasive approach. It's now been shown that for lung cancer operations specifically, for patients who need chemotherapy after surgery, that chemotherapy is going to be better tolerated, and patients can get more of the required doses of chemo after a minimally invasive operation. And now there are some studies coming out that show that there might actually be a survival benefit after minimally invasive chest surgery compared to the more traditional open approach. So I showed you that video just then. But again, technology continued to advance. Like technology I just showed you, again, we've been using that since around 1990, early 90s, and more recently in the mid 2000s, and in chest surgery around 2010, we started using robotic surgery. So now this is talking about technology on steroids, essentially. This is a picture of the Vinci Robot, which is the most commonly used one probably throughout the world. And this robot has 4 different arms. One of them will hold the scope that I use, and then there are 3 operating arms. You can see in the picture on the right, this is the surgeon console. So this is in the operating suite, just a few feet away from where the patient might be. And as you can see, the other arms are over this patient. And through a combination of 2 hand controls and about 4 or 5 different foot controls, I can simultaneously monitor and control all 4 of those robotic arms. So this is not, the robot is not really something that's operating independently. It's really telemanipulation. So it's me controlling the different arms and the different instruments. So like any new technology, we tend to start with more basic procedures. And as we gain knowledge and experience, we were able to do more advanced procedures. So this is another use of technology in medicine. This is an operation from probably about a year ago that I did. We're in the left side of the chest and we're sort of closer to the head, looking down towards the feet. So this over here is the diaphragm, which is the thin muscle that separates the chest from the abdomen. And this structure that I'm operating on over here is the aorta, which is the main artery that comes out of the heart. And the heart you can actually see beating just over here to the right of your screen. And this patient had a mass, what we call a para-aortic mass, literally sitting right on top of the aorta. So what I've found, I started doing robotic surgery right around 2009 is when I went through my training. So I've been doing this for 12, coming up on 13 years. The key benefits here have to do with the improved visualization and the manipulation, the precision of the instruments. So where I'm working here is what we call high price real estate. I'm working on the main artery coming out of the heart. The heart over here is just a couple of centimeters away. Between the 2 structures, deep in this recess is the aorta. We have the diaphragm over here. So it's really critical to clearly see the anatomy and be familiar with it. So you can see the precision that I'm using over here. I'm starting to dissect out kind of part of this mass, and you're going to see a little bit more of this. I'm going to kind of just jump ahead a little bit over here. But there are different instruments I can use. So what I did is I swapped out my left arm for a different instrument, which is a plastic clip that we use to kind of ligate that base. The instrument I'm using now has a cautery on the end of it, so I can generate some heat to divide the tissue, and that's why you temporarily see the smoke there. And then I'm going to take out that piece of tissue. That's just another clip ligating the base. And I can divide the tissue between 2 clips, make sure there's no unnecessary bleeding. Jump ahead just a little bit here. But now you can see in my right hand, I'm holding up the main mass over here. So I can swap out my hands if I need to. If I find it easier to dissect with my right robotic arm, those arms are interchangeable. And I'm going to put one more clip on the base over there. And then that's it. Then we divide that, and that kind of completes the operation. And then we're just going to leave a small drainage tube in, which typically comes out the next day, and then the patient can go home. So as I mentioned, whenever we have new technology, whether it's the robot or something else, of course, we tend to start with the simpler cases, like I said, and move on from there as we gain experience. Now, usually these are done for elective cases, but every now and then a patient presents a little more urgently or semi-urgently, and we can still use some of this advanced technology. So this is a patient that I operated on probably about 2 years ago now, who came in with a gunshot wound, admitted to the trauma service. The trauma service wound up consulting me because they were able to see, and there's the bullet fragment right there. They were able to see on chest x-ray over the series of a couple of days, this bullet fragment was migrating within the chest. And it got to the point where it was in a very precarious position. I'm actually taking it off of the superior vena cava, which is this purple structure right here, which is going into the heart. And this is the lung down here that I peeled away. So, and what surprised me was this very sharp, jagged edge on the bottom. So you can imagine if that bullet fragment migrated any more, it easily could have gone into the heart or into the main vein that goes into the heart. And that really could have been a lethal situation for this patient. So we elected to do this minimally invasive robotic approach. So, 3 small incisions, go in there and remove the bullet fragment before it migrated any further. Okay. So again, we like to think of the robot as another tool in our tool shed that we can use for certain operations. And then there's other technology that's come along. And this is the use of virtual reality. And this is something that I am now using almost daily in my thoracic surgery clinic. And we will occasionally use this in the operating theater as well. Now, virtual reality is not brand new. So in fact, its history actually goes back about 60 years. So it's been used in the cinema, and you can see somebody kind of puts their head in there and creates a 3D movie. A couple of years later, the first head-mounted display was invented. And over the ensuing decade,
It looks like we're having some technical difficulties, so we'll just wait for Dr. Mortman to sign back in. Sometimes when we're actually at the office, there he goes, he's back. I was going to say the connection is weak. There you go. Welcome back.
okay, so you can see it again?
Yes.
Okay, great. So this software started in the field of neurosurgery, and I looked at this product and I said that's great, it's very interesting. Can I use that in the chest? Can I use that for thoracic surgery? And the company said, well, gee, I guess you could, but no one has yet. So here at GW, we were actually the first thoracic surgery program in the country, or really in the world, to use this particular product. And we certainly use it in the operating room, but more commonly, we actually use it in our clinic to help educate our patients, as well as our trainees, our medical students, and our residents. And essentially, what it does is it takes any two-dimensional cross-sectional imaging. Let's see. There we go. So it'll take someone's CT scan or PET CT or an MRI, and they obviously have proprietary software that creates a three-dimensional image. So here's a patient's CT scan, and you can see they have a relatively large mass in the left chest, and you're looking at the same thing in 3 different planes: axial, sagittal, and here's what we call a coronal view, a front view, pretty large mass. You can see how this mass kind of lights up on a PET scan, and that makes it a little more concerning for us. So we take these kind of static images, if you will, these DICOMs, and we feed it into their software, and we create this 3-dimensional, 360-degree virtual reality product. And in our clinic, our patients are able to put on the headset so that our patients can become an avatar, literally walking through their own chest and looking at their own anatomy and their own pathology. So here in this case, the yellow, which you're seeing, is that large mass that I just demonstrated on the CT scan. So the patient can hold, it's almost similar to a Game Boy controller, if you will, and they can walk into or out of their chest. As they move their head around looking in the headset, they're actually looking up into the chest, to the left, to the right, and they can actually walk through the mass. So we've found this to be a pretty profound teaching tool for our patients. one of the things that we have to be cognizant of is, the health literacy of our patients, and the fact that they come with us with different levels of knowledge. And something like this really tends to level the playing field. So when they kind of see this firsthand and really up close, they do get a much better appreciation of why I need to operate on them. And we've studied this in a couple of different ways over the last few years that we've been fortunate enough to present at a couple of different conferences, showing that there's a pretty marked difference with the use of VR. So I'll just let this play out. So we've been using this, like I said, routinely for about 5 years now in my clinic to educate our patients and our residents. And then, as we all know, around March 2020, COVID struck us. And it was a difficult time for all of us. And there were a lot of things in the news around the world saying, well, is this real? Is this not? And why do I need to take certain precautions, such as maintaining 6-foot distance and washing my hands and wearing a mask? So all of those things were happening. And in March, we received our first COVID positive patient here at GW. And it was, again, a time where we're hearing lots of different things in the news. And what I was able to do was take the CT scan of our first COVID positive patient here at GW and convert that CT scan into virtual reality. And this is something that some of you may have seen on the news. This was carried by many different media outlets. And what you're seeing in yellow are the parts of the lung that were affected by COVID in this particular patient. This was a 55-year-old gentleman whose only prior medical history was high blood pressure, who unfortunately contracted the virus. He presented to an outside hospital where that original CT scan was done. Shortly after the CT scan, he deteriorated. He needed to be intubated, have a breathing tube put in, and then was transferred to our hospital for a higher level of care. And that's when we were able to create these images. And you can see how it was pretty profound. This was a time where we were learning new things about the virus literally every single day. So, we generated these images in the hope of further educating our staff, our patients, and really the public at large. What we're able to do now is essentially a virtual bronchoscopy. I'm taking you through the airway, deep into the right lung, further out into the smaller airways. And this is where you start to see more of that yellow, that COVID-infected lung tissue. So again, this 360 VR model, it literally takes a matter of minutes to go from the CT scan to these 360 VR images. Now we can zoom back out to get a wider appreciation of that. So we can use that technology really for any type of pathology in the chest. And so that's an example of virtual reality where the viewer becomes kind of part of that picture, kind of becomes that avatar walking through the scene. And that's a little bit different from augmented reality. You might remember Tony Stark, Iron Man here. And it's been used in several different places. Augmented reality is where you're essentially overlaying certain pictures onto a real image, much like the lower one. You can see the picture of the leg, and you're onlaying additional pictures to help plan a procedure, an operation perhaps, okay, or teach a trainee. So slight difference between augmented reality and virtual reality. So I want to shift gears a little bit at this point, because the question I want to ask is, well, what good is all of this technology and the research that we do along with it and the education it provides to our trainees and to our patients? What good is all this if we don't use it to impact the #1 disease that thoracic surgeons face? And again, this being November and Lung Cancer Awareness Month, that's really the bread and butter of any thoracic surgeon's practice is going to be lung cancer. And it is extremely prevalent within society. Okay, it's actually the #1 cancer killer in both men and women in the US. And I'll just draw your attention to the lower half of this. The top half shows new cases, but the bottom half is actually deaths in men and women. And you see how lung cancer is the top of both of those lists. And unfortunately, lung cancer takes more lives in the US than the next 3 leading cancer causes combined, which is breast cancer, prostate cancer, and colorectal cancer. So a very significant problem really for all of us. It's not a surprise what the #1 risk factor is, and that of course is tobacco. Years ago, we would say that the overall 5-year survival, and that's the statistic that we most commonly use in medicine. So what percentage of patients are alive 5 years after diagnosis or after treatment? Years ago, that number was maybe 15%. So for a very long time, it was 15%. We've made very little stride. We can say it's 20% now, but I don't think we should be patting ourselves on the back just yet, because that's still a pretty bad number. All right. Again, we know the #1 risk factor is tobacco. And if we look at the anatomy of a cigarette and what's actually in it, we know that there are over 7,000 chemical compounds, 70 of which are carcinogens or substances that are known to cause cancer. Okay, so these are some of the things that are in a cigarette when we light that on fire and put that in our mouths. And if we look at lung cancer by the numbers, we know that 1 in 16 people in the US will be diagnosed with lung cancer at some point during their life. There's about 235,000 new cases in the US this year, and that's 1 every 2.2 minutes. These are new cases, and unfortunately, there's about 160,000 deaths every year from lung cancer. And about 12% of the new cases are going to be among never smokers, and the majority of which are actually going to be women. So now the question that I have to ask, and I've been asking for a number of years, is, well, what's going to move the needle on lung cancer survival? How can we go from 20% 5-year survival to 80%, 90%? What's going to drive that? Well, is it going to be better treatment? And I would argue, no, that's going to help certainly to some degree, but that's not going to be a big driver. So if I'm honest with myself and I say, is a sharper knife going to increase the 5-year survival? Is a brighter scope that I use going to increase that 5-year survival? No, I mean, it's going to give that one particular patient maybe a better outcome, maybe, less pain and a shorter hospital stay. But when we look at society at large, is that really going to, increase that 5-year survival number? And I'd say no, because when we're talking about treatment, we can say that patient's already been diagnosed with lung cancer. Right? So better treatment, sure, that's going to help a little bit, but not as much as I would like. So what about early diagnosis? That's certainly going to affect things a bit more. So if we can get to these patients when they're stage 1, as opposed to stage 3 or stage 4, where it's spread to other parts of the body, yeah, that's certainly going to help drive that number quite a bit. But can we go one step further than early diagnosis, which I'm going to come back to in a minute? The answer is yes, and that brings us to prevention. So particularly primary prevention. Again, I thank Dr. El-Bayoumi at the start for giving my high school program a plug, because that's something that's always been near and dear to my heart. And if there's actually a survey that is conducted annually. It's called the National Youth Tobacco Survey, and it's a joint venture by the FDA and the CDC. And it assesses and monitors tobacco use in both middle and high school students. They usually survey around 20,000 students every year, every state, including DC. And the numbers, more recent numbers, I found somewhat staggering. The numbers I'm showing you here, these go back a few years now, from 2011 to 2014. The good news here is that we know that the use of cigarettes among these middle and high school students continues to drop. So just during this 3-year period, it went from almost 16% down to 9%. And we can say that's good, and it is. However, that good news has been offset by not so good news, because during that same period of time, the use of e-cigarettes and hookah went up about 800%. So that if we look at the left over here, if we look at the overall use of tobacco, there was really no decline over this period of time. It stayed right around 24, 25% for overall use. Because although the cigarette use went down, use of e-cigarettes and hookah kind of offset that. Now, if we look at the most recent numbers, these are the 2021 numbers, we know that more than 2 million youths from the US currently use e-cigarettes. So that's the most common nicotine delivery device at this time, is the use of e-cigarettes. We know 85% of the youths use flavored products. A little more than half use the disposables. And about 1 in 4 of our high school and middle school students use e-cigarettes on a daily basis. Okay. So for me, I think primary prevention is really the key, and kind of getting to our youths in our communities at a very early stage, which is why I started that high school project. And you might even say, well, we should be starting earlier in junior high and in grade school. And I would not argue with you about that. Okay. So primary prevention, I think, is extremely important. Okay, and we have to really start that conversation early on with the youths in our community. But let's go back to early detection for a moment, because that's important also. So early detection of lung cancer, this is something that's been looked at for decades. 50 years ago, 60 years ago, we looked at sputum cytology and kind of looking to find cancer cells in the sputum, and could that detect cancer early and save lives? And that didn't really pan out. There have been studies that looked at plain chest x-rays, and that didn't really pan out. Because when we talk about screening patient populations, we're really looking at populations that are at risk for a certain disease, but do not yet have any signs or symptoms of the disease. And obviously the goal is to catch that disease process early and decrease the death rate from that disease. So lo and behold, there was a large study that was done that was published in the New England Journal in 2011. This was the National Lung Screening Trial. And this was a trial of over 53,000 current and former, what they called heavy smokers. So patients that smoked the equivalent of a pack a day for 30 years. And these patients were randomized to getting either a plain chest x-ray or what's called a low dose CT scan of the chest. So they got an initial one at baseline and then annually. And this was really the first study that kind of hit that home run for us. And what the study showed was a 20% relative reduction in mortality, in death from lung cancer in that group that received the low dose CT scan compared to the chest x-ray. So this was kind of a groundbreaking study that came out within our field and really in all of medicine in 2011. And it was after this study that many hospitals and healthcare systems put together their own low dose screening program. And that's exactly what we did here at GW. I believe my nurse navigator Meg is on this call, and she and I set up our program here a little over 7 years ago. So again, when we talk about screening, we're talking about catching things early in patients who do not yet exhibit any signs or symptoms of the disease. And one of the ways that we can measure kind of the effectiveness of any screening modality is how many tests do you need to do to actually save one life from that disease? So when we talk about screening for cancer, obviously breast cancer, we typically perform a mammogram as the most common screening modality for breast cancer. So how many mammograms do we need to do to save one life from breast cancer? Well, the answer is somewhere between 900 and 1900, and I know that's a bit of a range. Okay. And then we can ask, well, how many colonoscopies do we need to do to save a life from colon cancer? And the answer is about 800. And maybe you can see the trend where I'm going here. How many low dose CT scans do we need to do to save one life from lung cancer? And the number is 320. Now, I don't mean to take anything away from any of our breast cancer or colon cancer patients or practitioners. We know that last month, October, was Breast Cancer Awareness Month, and I certainly don't mean to take anything away from them. But we tend to hear a lot less about lung cancer and about screening for lung cancer. So we have a very effective modality to screen for this disease, and it's a low-dose CT scan, okay? It is something that is covered by Medicare and almost every major insurer. The people who can currently get it and qualify it are aged 55 to 77. They have that 30-pack year smoking history. So again, that's the equivalent of 1 pack a day for 30 years. Or if they've quit smoking, they've quit within the past 15 years. Those are the basic inclusion criteria. Actually, I'm sorry, the age range, if I said it wrong, was 55 to 79. No, I'm sorry, 77. Inclusion criteria, okay? So we still have a lot of work to do, I think, in getting the word out to the public, as well as to our fellow clinicians about trying to screen as many patients as possible, so that if somebody does have a lung cancer, we can actually catch it early and take it out and hopefully cure that patient of the cancer. So Dr. El-Bayoumi mentioned at the outset about certain disparities that we see in medicine. And unfortunately, they exist in my field of thoracic surgery and lung cancer specifically. So are there racial disparities in lung cancer care? And the answer is, unfortunately, yes. So compared to white Americans with lung cancer, Black Americans are 16% less likely to be diagnosed early, 19% less likely to receive surgical treatment, and 7% more likely to not receive any treatment. If we look at the Latino population, they are 13% less likely to be diagnosed early, only 2% less likely to receive surgical treatment, but 39% more likely to not receive any treatment. And you can kind of see the trend here for Asian American and indigenous peoples as well. The only surprising finding had to do with Asian Americans or Pacific Islanders, were actually 11% more likely to receive surgical treatment compared to white Americans. I don't really know the explanation for that, but that is the statistic. So how are we doing? So these are kind of a national numbers that I'm showing you here. How are we doing overall when we look a little bit closer to home? When we look at the age-adjusted lung cancer death rate by the different states, we can see DC over here is in that lightest shade. So overall, our death rate from lung cancer in DC is actually significantly lower than the national average. I'm sure due to a variety of factors, this doesn't break it down as much. So just to kind of wrap up, and then I'm happy to take some questions. I think that primary prevention of tobacco use is critical. So if we can prevent people from ever starting to smoke, I think we can start seeing improvement in some of those numbers that I mentioned. Early detection for every eligible patient is going to be critical with the use of that low-dose CT scan. All right, so anything we can do to help get the word out to the public and to our fellow clinicians is going to be extremely helpful. Patient education is key. We spend a lot of time with our patients in our clinic, particularly our new patients, particularly if we're going to be talking to them about an operation that they need. And we found the use of technology, specifically virtual reality, extremely useful in educating our patients. Minimally invasive surgery is used for early stage lung cancer with extremely beneficial results. And what I didn't even get into yet, because this is a whole nother topic, maybe a teaser, maybe if you want to invite me back next year, next November, I'll come back and speak with you about some of the novel therapeutics that we're using within the lung cancer space. And these are called targeted therapy and immunotherapy for certain patients. So having said that, I am happy to entertain any questions, and I can stop sharing my screen here.
Well, thank you, Dr. Mortman. That was really excellent. I learned a lot. I did not know about the virtual reality that you are using. And I think that that's such a powerful tool because, you know, you can hear things or even read things, but especially if you've been given a cancer diagnosis, it's really much more difficult to absorb that information. So this is a very powerful tool. So I have some questions for you because I think we tend to concentrate on tobacco, which is definitely a cause of lung cancer. But what about some of the other environmental exposures? For example, we know that people, mostly men, that used to work in the shipyard or in construction or exposed to asbestos can have a different kind of lung cancer. Or what does air pollution do? Can you speak to some of these other aspects?
Yeah, we do. Like I said, so certainly tobacco, number one risk factor, but as you mentioned, there are others, whether it's radiation, radon, which is one of the reasons why, we check it in our homes, purchase a new home, have the radon level checked. Air pollution, we believe, is a factor. We think that there are some dietary and nutritional factors that are at play also, and those are being studied. And then genetics. There's probably not quite as strong as of a link of family history with lung cancer as perhaps breast cancer and colon cancer and some others. But there is somewhat of a link. So I think as every year, almost every month that goes by, we learn more and more about the genetics of lung cancer.
Mm-hmm. And since you brought up COVID, and you've showed us that incredible virtual, it's not virtual reality, virtual reality, the scan that you showed us. What do we know about COVID in terms of potentially any long-term impact on the lung?
Yeah, I think we're just starting to see some of that now in terms of, scar tissue in the lung. We think there's sort of a parallel between the degree of somebody's symptoms and, how long it lasts in the lung and the degree of scar tissue and perhaps fibrosis that we might see in the lungs. Whether or not that predisposes a patient down the road to a lung cancer, we don't know that yet. It's a little too soon. And that may take several more years still, but that's something that we're going to have to, look out for going forward.
Mm-hmm. Please talk to us more about the lung cancer, the CT scan screening. You mentioned low dose compared to just a regular CT, and how much lower is the dose?
Yeah, so it's roughly half of normal CT scan. Probably more of a difference also if someone were to get a CT scan with contrast. So relative to that, a low dose would be a fraction of that. It's a scan that, like I said, is covered by Medicare and just about every insurer at this point. The scan itself, it's going to take the patient longer to sign in at the radiology place than to actually get it. The actual scan literally takes about 30 seconds. Once you're on the table, it's non-invasive, so there is no contrast, there are no needles. We have an entire program that we've set up here at GW that is run by our nurse navigator. So that, the patients get the results, patient's provider get the results. The results can be anywhere from, hey, this is a normal CT scan, we'll see in a year, to, hey, you actually have a suspicious looking nodule that could be a lung cancer, and we'll go ahead and send you to the appropriate specialist at that point.
Mm-hmm, mm-hmm. Well, there's nothing, I think, more satisfying than picking up, well, it's not exactly the right word, but when you pick up a cancer at a very, very early stage, especially if it's a lung cancer where, the outcomes are not great. But what do you think are the biggest reasons that people are not getting these scans?
Well, a couple of factors, and I'll go back half a step there, because the outcomes have a lot to do with when you pick up that lung cancer. And again, that's the whole point of trying to find this early, so that in our practice here at GW, kind of employing some of the latest technology that I showed you, which would include, a minimally invasive operation for an early stage cancer. When we talk about that 5-year survival number, so in our program here at GW, we have a 5-year survival for stage 1 lung cancer patients probably between about 80 and 90%. And
Wow.
historically, that number would be down about 60, 70%. So it has, very much to do with how early you catch it and what stage that cancer is in. Getting to your other question in terms of, why aren't we using this more broadly? And it still has to do, even though that study that I mentioned was published, 10 years ago, and our program's been up and running for about 7 years. Some of the guidelines have changed along the way. It's been a little bit of a moving target in terms of the exact age ranges. The upper age range from that study was 74. The U.S. Preventive Services Task Force a couple years ago recommended that upper age range go to 79. CMS that actually pays for the scan kind of split the difference and said, well, it's going to be 77 is going to be the upper age. So there's been somewhat of a moving target with some of these things and the reimbursement for it, over the last several years. But the main message that obviously I'd like to get across is that it's an extremely effective tool for that patient who is at risk and meets those inclusion criteria. Very quick scan, like I said, literally about 30 seconds, non-invasive. And hopefully we see many, many normal exams, which is wonderful. And we'll say, come back in a year because it is recommended to do annually. But again, if somebody does have an abnormal scan, the whole point is to catch that abnormality early so that we can find it. And not every abnormality is necessarily lung cancer. In fact, the majority are not going to be. So it's not like, just because you have an abnormal scan doesn't mean you're getting an operation.
Well, and, as health disparities as well as impact, we should be, you mentioned an incredible statistic about lung cancer causing more deaths than the subsequent 3 cancers, breast, colon, and prostate combined. Right. So we really need to put this on our, really at the very top of cancer awareness. And I think, there are a variety of reasons why breast and colon, well, breast and prostate get a lot of attention, but this is certainly important. I wanted to also comment on a statistic that you showed us about DC having less of a lung cancer rate. I bet you, though, if you go into the specific neighborhoods, you're going to be seeing a difference. One thing with our great wealth concentrations here in DC, we can be named I think the healthiest city because averages, don't speak to the disparities. So we actually lead the country per capita in cancer death in the country overall. So I would be curious to kind of see what that lung cancer is. And especially, I'll also just add this, our friends and community leaders who live in Southwest, I learned something new, and that just last week, that it's the most gentrified area in the United States. And of course, it also has the highest rates of pollution from water to soil to air pollution. So that's kind of a cancer corridor. And I see that there is a question here. How can we take better care of our lungs? That's from and then also, if one resides in multi-generational housing with environmental pollution, should they get tested for lung cancer? Maybe we'll take that second one first.
Sure. So how can you take better care of your lungs? That's obviously not an easy question, but I think, basic things. If you're smoking, stop. If you don't, please don't start. But as I tell my patients, particularly if they're recovering from an operation, you have to think of your lungs as a muscle, is what I tell them. And really the best way to exercise that muscle is to get up and walk. Just simply walking. You don't have to go for a jog, you don't have to run, but maybe walking a little briskly to the point where you kind of feel you're getting your heart rate up and you're breathing more deeply. That's how you're going to exercise your lungs, especially if you are recovering from a lung operation. But really, in general, it's not necessarily that you have to do an hour strenuous workout 6 days a week. Simply going for, a 30-minute walk every day, you will reap the benefits. But also obviously, speaking with your primary care physician, because everybody's situation is going to be unique, may have other underlying health factors. So it certainly is a conversation to have with your primary care physician during your annual checkup.
And I think the second question actually had to do, let me just go back and take a look at that.
About the multi-generational.
Right. If one resides in multi-generation housing with environmental pollutants, should they get tested for lung cancer?
Yeah, again, so really the most effective test, if you will, that we have for lung cancer is that low dose CT scan that I mentioned. So again, it has to do with, are you a current or former smoker, and how much you smoked. So certainly if you meet those criteria, then again, I urge you to speak with your primary care physician about, ordering a low dose CT scan. If not, or even in addition to that, you have to look at the factors that you can mitigate. So, having your home tested for radon, do you live, near some, high voltage wires that could be, a potential source of radiation? Do you have, a lot of lead-based paint, in your home? So there's certain things that you can check for and mitigate. Certainly, if you live with one or more smokers in that multi-generational household, it's important to keep in mind that about 15%, roughly, I think I mentioned 12% during the talk, of the new lung cancer patients that we see are people who have never smoked. Okay, and again, the majority of them just happen to be women. So whether you live with a smoker, years ago, obviously smoking was commonplace, in the workplace. So we talked about people who work with smokers. So there's certain things that we can try and protect against.
Mm-hmm. So there's, I think, probably the final question from Ms. Keys, and she asks, if you have lung nodules, should they be removed?
The short answer is going to be no. Not every lung nodule needs to be removed. It has a lot to do with what they look like. We get a lot of information on the CT scan. CT scan not only tells us where something is and how big it is, but there are other features that we look at on the CT scan that can make a nodule more or less suspicious. It has a lot to do with how long those nodules have been followed. If they've been followed and stable over the course of many, many years, then that would speak against the cancer. And I would argue that they do not need to be removed. So again, the majority of nodules that we identify on a chest x-ray or on a CT scan, the majority are not going to be a lung cancer. So it's important for us as clinicians to kind of tease out the ones that are more suspicious, in that higher risk patient who might need a biopsy or who might need surgery. So just because you were told that you have a lung nodule does not mean that it's cancer necessarily, and certainly does not mean that you necessarily need an operation.
And final question, Dr. Mortman, if one is a smoker and one quits, can that reduce lung cancer happening?
The short answer is yes, absolutely. So I've seen many, many patients over my 20 years in practice who will say, well, I've been smoking for, how long, and why should I stop now? And the very short answer is that because it will decrease over time, it will decrease your chance of not only getting a lung cancer, but all the other smoking related cancers. So whether, it's throat cancer, esophageal cancer, bladder cancer, stomach cancer, whether it's heart disease, whether it's a stroke, the risk of all of those things go down with time. Some of the changes that we see in the bloodstream, the changes to heart rate, to blood pressure, we will see those beneficial effects within minutes of somebody's last cigarette. So some of those changes we can see within minutes to hours. Some of them will be weeks to months to years.
And with that, thank you, Dr. Mortman. Thank you for the excellent presentation that you gave, and thank you for teaching us about these new technologies. And thank you for all the work that you do with young people. You are impacting, I'm sure, the workforce, getting kids interested in health careers. You're hopefully getting them immunized against even starting smoking in the first place. And we certainly appreciate everything that you do for patients, but people at large in Washington, D.C. So thank you very much. And I hope that everybody has a good holiday, Indigenous Peoples Day, Turkey Day, and that everybody stays safe, watches a lot of football, sleeps, eats, the whole thing. So take care, everybody. Thank you.
Thank you.
Good night. Good night.